Hey guys, welcome back to The Pathway. Taylor Henrik here with Sarang Patel.
Hey guys.
Today we're going to dive into a couple cool topics. We're going to talk about conventional psychiatry as well as interventional psychiatry. Talk to you about the pros and cons of both, and hopefully you'll find some information in here that could be useful. Here we go. So today is going to be a little bit more informational. No controversy today. Topics that are going to be things that we think will be important for our clients to hear. Clients, listeners, anybody who's interested in this type of topic. So I hope today we can cover different medication options that are out there, whether it's an oral medication, an injectable medication, maybe a patch that you put on the body, maybe talk about some of the digital therapeutics that are available, as well as some of the newer treatment methods, maybe something like a Esketamine, or Spravato, talk about TMS and other interventional methods that are out there. Does that sound good?
Yeah, I like it.
All right. So let's start conventional, okay? Your modus operandi or your MO is to go with an oral medication.
Whoa, my what?
I had to do it right off the bat for you.
I can't even spell that.
It's okay. Your MO is to dive in on what? Oral medications, right? Once daily, twice daily, 3 times a day, you name it. We know that this is our bread and butter. Okay, we've got various different medication classes that are out there. What's cool, and one thing that I think is worth mentioning, is that we're starting to hit some new neurotransmitters, right? So we've got some newer sciences being introduced. We have a lot of medications that are in clinical trials right now, a couple that are phase 3, working with different neurotransmitters, and a couple medications now where we're exploring a whole different neurotransmitter pathway, right?
Yeah, so let's go over like oral, right? We talk about, and I think we can talk about classes of meds is okay here, right? You say antidepressants. We have our SSRIs, we have our SNRIs, we have our NDRIs. All these NRIs, right? NDRIs that we are talking about that people have always heard about before, right? Your Zolofts, your Lexapros, things that are generic now that have been around for a long time. And you have these antidepressants that clinically, as far as, not clinically, I should say, in school, literature-wise, we're taught to go down this pathway of start with one SSRI, max it out, go to the next one, max it out, add another one if you need to, max it out, and then keep down this pathway here, right? When clinically we realized that you don't have that kind of time with your patients, right? And I think in the future we talked about maybe talking about the SARD study in general here more in detail, right? We can do it today if you want, but we want to bring Dr. Amin on here and talk about it as well. But I think we see that when it comes to oral medications, I don't know if I would say that times have changed. I don't think that's the right way to say it, but I would say that our options have changed.
Yes. And
now we don't have to go down the same old rigmarole pathway of SSRIs and this whole same thing. And now the idea is you can introduce an atypical antipsychotic medication earlier if you'd like to, because you have cleaner options than you did before.
Yes.
So let's say you're talking about depression, PTSD we talked about earlier. These things as well, you don't have to wait 6 months, a year, 5 years to diagnose it, but then another 1 to 5 years just to get the right medication.
Absolutely. In a different way of putting it is we don't have to wait for the depression to become treatment resistant, right? We can almost take a more proactive approach by augmenting or treating adjunctively with secondary medications, coupling with our baseline antidepressant.
Right.
When talking about depression. Right. How about anxiety? What are you looking at there?
So I think the same thing, right? You look at what is actually approved, and you may say that some things don't have the actual diagnosis for it, or indication for it. However, we know they could help. And clinically, you see what helps as well. That may be off-label, we talked about as well earlier. You may need a mood stabilizer that could actually help with anxiety, we've seen before as well, clinically, right? And again, it's one of those same things. If you have 5 different prescribers, you may get 5 different answers, right? So we know that going into this. But you have to look at it where it's not just the same old, start with this one, go to the next one, start with this one, go to the next one, same kind of thing. You have to look at it, it's like an art, right? There's a science here too. You're trying to see what combinations could make a difference. They could be 2 low doses of medications, of an antidepressant and a mood stabilizer. That works well for your anxiety control, but not for mine.
Correct. Customized, tailored treatment, right?
Yep.
Tailored with an I. Tailored treatment. But theoretically and in practice, I appreciate that you said it's not always a science, it's sometimes an art. what works for one individual will not work for the rest. And that's something that we really, really appreciate at Pure, right?
Yeah.
We appreciate the non-cookie cutter, non-conventional approach when it's needed, right? So, and one thing that I want to mention is that some of the companies that are bringing out newer medications, they're pulling data or they're looking at concomitant anxiety, concomitant depression, and seeing how their medication did to give us that option, right? The indication may not be there, but is it plausible for us to say that this medication could help reduce the intensity of your anxiety? Yes. It's like they're opening the door for us as prescribers to utilize that medication when it's multiple birds, one stone, right?
Yeah.
Good.
Yeah. And I would argue that, I think maybe we said this before earlier, is that I think it's very hard to work in psychiatry and not use things off label. I would almost argue that if you don't use things off label, you're never going to get control over all of the mental health issues you're going to see because you don't have enough options.
Right.
And if you do, you're going to be like we were doing 20 years ago, and what are we getting at? Nowhere.
Right.
So I think that the combination of medications, low doses, obviously high doses of some medications, maxing 2 doses out may be indicated for an antidepressant and a mood stabilizer, for instance. You know, we talk about new grads that come on board or new prescribers that are like, or different from different industries, right? From family care, primary care, whatever it is. We'll say, well, your antidepressant should be 2 max dosages. You might need to get to your max of Lexapro, your max of Zoloft, and the combination is very unique, where it's like literature-wise, not really indicated-wise. However, in clinical practice, we'll say, hey, we see it and it works.
Yeah.
So I think the conversation is there's no right or wrong answer in that sense, as long as the patient's safe and obviously feeling better. But you may have to get to that point, and you can't be necessarily scared to think outside the box in psychiatry when it comes to these medications. Otherwise, you never really get control over it.
And everybody's different.
Everyone's different.
We don't have the luxury of having a blood pressure reading, a glucose level, a BUN creatinine. We're working subjectively and objectively in this case. Yeah. And a lot of times we have to call upon our own clinical experience to see what's worked well, right? And again, not speaking from a medical advice standpoint, this is informational. This is our experience sharing it with our listeners.
Yeah.
There are instances where a medication, like let's think about duloxetine, right? You kind of find that client that has the chronic pain, neuropathic pain, suffering from depression, anxiety, doesn't want to gain weight. Hey, maybe this is the right med for them, right? Older medication option, but just pointing out the fact that we try to nuance the medication to the circumstance, right? We can't always go to something brand new. A lot of times you and I have an affinity to use the newest medications because we know how to work within the confines of the insurances to get those medications approved.
Right.
And it's exciting for us to be able to reach for those knowing that they're more well synthesized and there's less potential side effects, right? But overall, we want to utilize what's appropriate. And in instances where we need to reach for off-label, do it in a place where we feel very comfortable with making that decision.
Right.
Moving from the antidepressants and the anti-anxiety medications, what about stimulants? Talk to us a little bit about what you're seeing with stimulants, maybe noting some of the newer options that are out there, highlighting maybe some of the oral methods as well as the patches.
Yeah, I think so. If you look at short-acting stimulants versus long-acting stimulants, and again, everyone reacts a little differently. Some people get irritable, some people don't get irritable on these medications, you know, whether at the peak, at the drop-off, when it kind of comes off blood concentration-wise. Everyone's a little different here. However, I would argue that it's generally a better idea to try to get them on a long-acting stimulant, one, less need to take more medication throughout the day, right? And less ups and downs of blood concentrations. Of course, some people don't tolerate that well, so it's not a cookie-cutter answer here. But I argue that extended release medications, some medications you may take at nighttime that could kick in the morning, could be a good option for your patients because that morning lag that you may have, especially for our kiddos, right? Or myself included, right? That first hour or two before you get the medication in your system, that's a big struggle.
Yes.
And if you get off on the wrong foot in the morning, the whole day's kind of wacko.
You got it.
At least for me, at least.
You got it. And branching off of that same topic, talking about the extended release versus immediate release, compliance.
Yeah.
It's difficult to remember to take meds multiple times a day. And I share that with my clients all the time. Hey, is this going to work for you? Do you feel comfortable with going with this regimen, this frequency, this dose, recognizing that it's not going to be easy to remember and stay on track within an hour range, 2 hour range, whatever we allow for, right?
Yeah.
Okay.
Even your kid at school, right? If they have to take a dosage at lunchtime again, they have to remember, the teacher has to remember, or I guess they remember there, but now they have to leave the classroom, make sure to get the medication at lunchtime. Yep. You as a parent have to fill out a form. The school has to get that form, all these kind of issues. If you can get away with a morning dosage that could hopefully last them long enough, and the blood concentration would decrease after they get home from school, that's the ideal way to do it, right?
It's so much more convenient. It decreases the amount of potential human error, right? The nurse is sick that day. Somebody's not in the office. Somebody gets displaced. The kid forgets to go down. Yeah. There's multiple different factors that can influence not getting that medication. Now the afternoon's affected. Now you're missing 6th and 7th hour and you're not being able to focus, participate, be engaged. Maybe you get in trouble that day. You know, like impulse control can be worse that day. multiple different factors that can influence how that individual participates or does.
Right.
Academically or professionally. It can also be the same case for someone who forgets to take the NIR dose in the afternoon at work, right?
Yeah.
How about moving away from the stimulants or non-stimulant options? Let's talk very briefly about mood stabilizing agents.
So you have your, I think, mood stabilizers. I would argue that we put in antipsychotics in that class as well, right? So that term, I know we could spend a whole hour talking about this here too, and I know a lot of people talk about it differently, but we say antipsychotic medications. Obviously now we're talking about the newer age ones, being more dopamine modulators, so affecting dopamine more, and we're obviously simplifying it here drastically here. But the idea is that we have these newer age options here that are available that can be given at night, that can be given twice a day. That could be, I always say, like a newer car. It's your older medications, but more efficient, right? You still are trying to get from A to B, for sure, right? Psychosis under control, moods under control, whether it's mood swings, racing thoughts, irritability, even depression control being better, even anxiety control being better. We may have all these symptoms we need to get better here, from being unstable to stable, from point A to point B, but these newer age medications can be cleaner. And by cleaner, I would argue, and maybe we both would say, it's maybe less weight gain,
right?
Maybe less issues with sedation, maybe less issues with can't anything else, metabolic changes, right?
Yes.
And obviously, again, simplifying it drastically here as well. But you hope to see, and I don't think that what I argue is that we, as obviously being part of Pure, the biggest thing we try to tell is that we don't limit the prescribers on what they should be able to prescribe, but it's our job to know what's available and to be able to say in the confines of the insurance, unfortunately, right? But also knowing how to work around that is to say, all these are options, both new and old. What fits your patients the best?
You got it. And that's where the prescriber has to educate themselves on an ongoing basis. You and I are constantly learning. Like we share articles with each other. We're sending stuff to each other because we want to be on the cutting edge. When something new comes out, I do appreciate that we're both early adapters. We both want to try it. I want my clients, I want to get experience for me, and I want my clients to benefit from that potential new option that's out there.
Yeah.
I think of the newer medications as being further synthesized. They're not a derivative of the old medications. They're new. They're reworked. Yeah. It's not so-and-so 2.0. It's a new medication. It's differentiated itself from what's out there. Let's give it a try.
Yeah.
Your body hasn't reacted to this medication or a dopamine modulator before. Let's see how it works.
Yeah.
Right? Conventional methods or the older methods may work for certain individuals, but you have to monitor for metabolic changes, weight gain, sexual side effects, glucose level changes, whatever it might be, right? Amongst other potential side effects. Yeah. So it's important for us to be aware of those. To round out our medication conversation, let's key in on real quickly on hypnotic, sedatives, rescue medications. There's other classes of medications outside of these core ones that we've spoken about that may be introduced as either add-ons or primary medication options.
Yeah, I would argue, I love sleep. I don't know why I talk about sleep so much, but I would say that these hypnotic medications...
You barely sleep. That's the funny part.
I don't know why this is a big thing, but I think it's so important. Maybe because I feel like every day we talk about sleep with patients is a lot of times these medications, we have our benzos, we have our hypnotic medications, like, your Ambien, Lunesta. You have these medications that are obviously there as well. You have these newer age medications that are harder to get that work on orexin, right? Our awake chemical. And obviously, again, simplifying it drastically, medications that work on melatonin 2 receptors, all these kind of different things. It's hard in psychiatry because there's actually not a lot of medications that are actually that effective at sleep control that you want your patients to take long term.
You got it.
Right? So the ones that we do have access to that I think work on orexin, maybe the copays aren't that great, maybe the coverage isn't that great, maybe the companies are smaller. But you realize that those medications that I think in our clinical experience have worked so well for our patients on orexin itself, right? That we look at, they're clean, they're efficient, but we don't have enough options out there.
Right.
And you wonder, like, hey, when is one going to come and just stick? As far as a stick meaning availability.
Absolutely.
I'm going to get it this year, but I'm also going to get it next year.
Right. And give us that longevity.
Right.
A lot of the sleep options, like you mentioned, are short-lived. Right. They're meant to be PRN, or they're meant to be taken over a short period of time and then dropped. Yeah. Right. It's not a long-term fix.
Yeah.
But I like that you brought up those options. It's nice to see that there is some emerging science there. There are options, but access, availability, and awareness.
Yeah.
Right. A lot of people aren't educated on them.
No.
It's something that you do really well, utilizing some of the medications in this newer class. Right. But not everybody does.
Yeah.
Not everybody even knows they're aware.
And I think, we could be controversial here a little bit, is that when you look at some people treating sleep, right? I find it very hard and challenging, in my opinion, but I'm going to say anyways, is that how do you treat someone's sleep, actual insomnia, or a secondary aspect of depression that's causing insomnia, whatever it may be, right? Bipolar is causing insomnia. How do you treat that with an atypical like Seroquel first, prior to using other options that you think could get approved? orexin, maybe some lower dose hypnotics, whatever it may be. Obviously, hypnotics come with its own risks there too. But I think it's hard because we see a lot of that come from primary care and internal medicine as well, that they're coming to us on Seroquel for sleep when realizing that it has its own baggage.
Right. I think one factor, not even one factor, a couple things that go into this. One, I often recommend sleep studies for my clients. Yeah. Let's make sure that it's not an underlying, sleep apnea or other sleep-related conditions. So send them to a sleep specialist, get that done, and then it's going to further your conversation. Secondarily is hone in on the diagnosis, right? What type of insomnia is it? Is it a primary insomnia and everything else is secondary? Is it psychopharmacological? Is it adjustment insomnia? Is it something else? There's so many different forms of insomnia and sleep disorder. It's important for us to further classify, and then we can cater the medication to that condition.
Yeah. One thing talking about sleep too, I don't know why I do this all the time, but is I have someone we're talking about this as well, is that temperature regulation for sleep is such a big thing that we don't talk about, right? Mm-hmm. So ideally they say like, obviously if you should sleep, it should be at a lower temperature. Mm-hmm. But I have clients that are the opposite. Mm-hmm. Their depression and their sleep is better in the cold, but some it's better when it's warm. Mm-hmm. So I think you have to also see what works for that person there and see.
Absolutely.
Sometimes you can't really change it, right? You can't really change the temperature too much.
Yeah.
Especially if you're married, but
I have broad spectrum recommendations for sleep that I like to cast out for my clients before I dive into medications for sleep, just because you're introducing something almost for a byproduct of something else. So I always like to tread lightly, and we always come back to sleep. It is kind of funny.
I don't know why.
We should be sleep doctors, I guess.
Oh.
Sleep specialists. But anyways, I like that that's kind of like the landscape, right? Of the different medication options. Oh, you know what? Before we dive into interventional, I'd like to talk about LAIs. Can you take us through what a long-acting injectable is and what are the benefits, maybe pros and cons?
Yeah, so I think when it comes to the injectable medications, I think compliance is a big thing that we talk about here too. Obviously, it's not what they actually talk about when as far as indicated for it, right? They actually can't speak on that because they're not actually studying compliance. But I think the ideal goal, and again, simplifying it again, is trying to keep the blood concentrations at a higher level, at a more consistent level with less ups and downs, right? Because technically when you take an oral medication, if it's at nighttime, it should be the same time every day. If it's 9 p.m., then 9 p.m. today, 9 p.m. tomorrow. No one is really like that, obviously, whether you're working or non-working. I think it's almost impossible to get the same exact time. It can happen, but it's very, very hard. So you use an injectable medication to get better control and stability. I think with that comes compliance as well, right? Just saying it. That if you can get someone on injectable medication, whether it's once a month, once every 2 months, once every 3 months, sometimes half a year, right? Some clever names out there too, that I think that you can actually get better control over it over time. Now, again, it's the same thing. Some people do really well with injectables, some people don't. So it can't be all injection and all oral or not. And sometimes it's a combination. Some do really well with an injectable medication, long-acting, once a month, once every 3 months, and they have these PRN medications that are oral or every day that are oral that help them stabilize completely. So you have to look at it all together and say that you have to, again, be aware of what the injectable medications are. And not all of our oral injections come in, obviously, oral medications come in an injection form. So it's just kind of seeing that, again, that combination, that artwork of how you want to paint that picture together with all these options of your medications.
For our listeners out there who might be interested in exploring long-acting injectables with their provider, say it hasn't been proposed. Some providers aren't huge clinical fans of LAIs, others are.
Yeah.
What would you tell, or how would you educate a patient who might be considering broaching the topic with their provider, or maybe is about to go on to an LAI?
So I think if you've never heard that there are injectable medications, I think it's important to at least ask your prescriber or whoever it is, hey, what options do I have? I know I'm taking an oral medication. Is there a patch? Is there an injectable medication? What other options do we have, right? And you want to know that because you want to see what has more efficacy, what works better, what makes your life easier as a patient, right? I think I always give the example, if you take a medication every single day, you have to take 365 times taking this medication. If you take an injectable once a month, it's 12 times in a year. Obviously you can go lower than that, obviously, as far as the less frequent it is, that injectable medication, but it could make your life easier. Yes, it's annoying for that first time maybe compared to taking an oral medication. However, it's a lot simpler. It can be over time, right? If you look at the time it takes throughout the year.
Good. That's really sound education to give, and I appreciate that. I just think it's a good opportunity for us to educate and prepare someone who may be considering, maybe they've looked into some of the options that are out there.
Yeah.
I'd like to take this opportunity to switch us over from conventional psychiatry, okay, quote unquote conventional, to interventional psychiatry. If you can open up our conversation today, a couple things that we'd like to discuss, maybe digital therapeutics, theoretically, I'd like to talk about TMS, if you can take us through that, and then talk about esketamine or inhaled esketamine, Spravato.
Yeah, so, we talk about, what's the first thing we said? Oh, digital therapeutics we'll talk about, right? So there are some medications, and again, we have to simplify this drastically here, and I think we talk about having more detail about this in the future as well, but when you talk about digital therapeutics, there are obviously oral medications that can be digitalized that you could say as well, that you could track if you take the medication so you don't forget, obviously give you a nice app to kind of see how you're doing, all these kind of aspects to it. That is a cool avenue that started a little bit years ago, but hasn't really, I think, taken off as much as we thought it would, or maybe they thought it would as well. And we don't have many options in that space as well, right? I think we only have one currently at least, and maybe there's some being studied as well. Then when it comes to patch formulations, am I missing anything else digital-wise?
One thought that I had was I know that there was a gamified version.
Oh, yeah.
If you can dive into that.
Yeah, so there's a gamified version that can treat ADHD that's approved by the FDA, right? So
Within the last year?
Yeah, within the last year, right? That is, you can play this game, the individual can play this game for, I think, X number of weeks, whatever it is, maybe 6 to 8 weeks, whatever it goes, and it should in turn help with ADD symptoms. Now, again, it's obviously this does not cure ADHD, does not solve the problem at hand, obviously, but it can aid in the aspect of therapeutic services as well as medication management with this digital thing as well. And I'm always a proponent that tell people, hey, like less meds, the better in general, right? Like we always kind of say that, right? So if you can do this digital game, and even if it doesn't necessarily quote unquote work, let's just say, it's worth the try.
Having never prescribed it myself, my familiarity with it is that it helps with sustained mental effort.
Right.
It teaches inherently how to stay on task, how to avoid distraction, and avoid, misplacing or forgetfulness.
Yeah.
Yeah.
Just trying to help train that brain, right? A little bit there, right? So I always give I don't know why, but I think about it like when you're growing up, you have those things like brain teasers, you always kind of do. I always feel like it's like that. You're always trying to like repurpose the brain, kind of retrain it a little bit there to kind of be more efficient if you can.
You got it.
So you have those digital therapeutics, and then you talk about, let's say TMS, right? So TMS, obviously, there's a lot more approvals coming through that as far as what insurances will approve and cover and pay and reimburse.
What does it stand for, TMS?
Transcranial magnetic stimulation, right?
Perfect,
so
thank you.
Essentially, simplifying it is you're sitting in a chair or whatever you want to kind of say in a room, and they're using, again, simplifying it drastically, again, magnetic stimulations with electronic pulses to kind of help stimulate certain aspects that are targeted in the brain to release neurotransmitters, to fire, to be more efficient, just kind of simplifying it there. There are more and more indications being approved by it. There are more and more companies that are creating TMS, different types of machines, different coil systems you can have, just kind of make it, kind of get into the weeds a little bit there too much. But essentially, you can treat depression, anxiety, OCD, some studies with PTSD for this as well. It again comes down to, does your insurance cover it? Is it available in your area as well, right? Something you can drive to, you can get treatment, you can drive home from that treatment yourself. Pretty simple to do. It is a little cumbersome, but it can be, hey, once a day for 30 days in a row. So obviously, even if it does take you only an hour to get there and get the treatment, come back, it can be hard if you're working or a family, whatever it may be.
The time allotment, right? Yeah. That's probably the most difficult portion of TMS.
Yeah.
Because the side effect profile associated with it from all their clinical trials is very minimal.
Yeah.
But it is a time-consuming topic and treatment method to undergo.
Yeah.
But in some instances and with individuals we've both seen, the benefit is there, right?
Yeah, I think it works really well for a lot of patients. Time is one thing, cost can be one thing because of copays, whatever it may be, and it's all state dependent, depending on what state you're in, what's available in your area as well. So that plays a big role, but definitely a good option to consider with your patients. I am a proponent of interventional for sure. I think that I always try to, at least with my patients, recommend some unique, in my opinion, my combinations I think work really well, right? Mm-hmm. So lower dosages of certain things and combinations could work really well prior to interventional, but you could also do that while doing the intervention as well to kind of get the better treatment faster if you can, right?
Absolutely. So getting on top of it a little bit sooner has been something that I've been focusing on. I've found myself clinically referring a little bit sooner for those modalities. Let's get evaluated. Let's see if it's an option, right? Because if you're waiting until you're in a state where you really feel like you need intervention or you need interventional psychiatry, it's almost too late to then refer them over and get the consult done and get the evaluation done and then get their insurances ironed out. Get it done if you're even considering it.
Yeah.
Yeah.
I think if insurance has covered it a little bit easier, I think we'd refer a lot faster. I think just seeing how cumbersome it is to get it approved and the process it is to get it kind of done as far as, hey, is it approved, what the cost would be, all that kind of stuff. The timeline we already know, how long treatment would be. if we could get that part a little bit quicker and easier, then I think we refer more people over to that a lot faster, I would say.
Absolutely.
And obviously lifestyle stuff can make a big difference too. Financial class, work schedule, all that kind of stuff plays a big role. And then from TMS, you talk about, obviously you said, ketamine, esketamine. You have obviously intranasal ketamine, and obviously you have IV oral. That's also used as off-label as well. Again, being studied more and more, becoming more and more readily available. We talked about providing the service here at Pure here in the near future. We said within the next 1 or 2 months we want to offer this as well. And just something you could do for your patients that could be another option there for you, right? I think when you look at why do you create these service lines, you look at your patients and you say, well, I want to be able to provide you the next service line available as well if I can. It's not just oral injections, digital long-term injections, and oral LEIs as well, you said, but it's also the treatment as well as far as interventional as well, if we can offer that too.
For our listeners, who qualifies to be a candidate for Spravato treatment?
So treatment-resistant depression, so technically a failure, again, deemed by insurance companies, right, as far as what is considered treatment-resistant, right? We could all have different opinions on it, but failing 2 antidepressant medications, now even feeling, I think you could say suicidal thoughts as well, right? So treatment for active suicide ideation as well, which we don't really have many indications for, if any, right? That we could say could actually be effective, which is with esketamine, intranasal.
And for what age ranges are TMS and Spravato appropriate?
So 18 and above, obviously we're going to talk about it here when it comes to these treatments, which unfortunately, fortunately, are most of our medications come with that, right? Or 18 and above. But you look at it for something that you can do for your patients. When it comes to ketamine treatment, it's a little bit more cumbersome because you can't drive yourself there. Well, you can, but you can't drive home, so you need transportation. So typically you need someone to take you there, take you back home as well. You get treatment there. You have to be monitored for a couple hours. Obviously, it's nice and comfortable, all that kind of stuff, but it can be a little bit more cumbersome. But it does work really well.
Good. And for our listeners who might be piquing an interest here, hearing about TMS or Spravato, I'm going to pull a farm rep question and ask you, who do you feel is the appropriate or the ideal candidate for TMS or Spravato? How would you answer that?
I don't know if I have is the best candidate, the most appropriate patient. I think every patient, obviously if you're talking on label based on age range, is appropriate, could be appropriate for that treatment, right? So the person that comes to the door should be considered for an injectable, a digital, an oral medication, a patch, interventional as well. You have to look at all the options you have available and then see what fits the mold for that person. You can't just pick it.
You hit the nail on the head. The answer is there is no ideal candidate.
Yeah.
You make all the options available. You allow your client to educate themselves. You educate them. You make sure that they have all the data that they need to be able to make the decision with you as the clinician. And then you choose a path that's going to work best for the client.
Yeah.
Nice answer.
Well said.
Well done. I hope that this was an informative conversation about both conventional and interventional psychiatry, and we'll see you back next week on The Pathway.